Right, so this is a video about the OSCE examination questions, example questions up, so I'll move my head to a more appropriate position. Right, my name is Prepartion and I'm an optometrist. I've worked in practice for about 17 years. I've had a few pre-reg optometrists, and what I'm going through today is some examples of questions that could be asked in the OSCEs, and some thoughts on how to answer them. The first thing that you should definitely do is have a look at the College of Optometrists website, have a look at the OSCE questions that they've got as examples, and understand how different these OSCEs are to the stage 1 and stage 2 assessments. The preparation required for them is quite different. You have a very short period of time in order to get the correct answers across. I have done some OSCEs. I did them for the professional certificate in glaucoma and the professional certificate in medical retina, and they are quite daunting even for an experienced practitioner. All I can really suggest is have a look at some of the YouTube videos that are around, just to get a good feel for it, and the college have an OSCE example on their website as well. Right, what I've done is just come up with some scenarios based on things some of my pre-regs have said over the years, on the sorts of questions that can come up, and just to give you a feel for the things that I would come up with if I had the same assessment. Obviously there is a massive amount of stuff that can be covered, but the OSCE is really just to sample your knowledge in order to decide whether you're competent to practice. So I'm just going to run through some examples that I came up with. So the first one was a patient attends and they have a sight-threatening keratitis due to contact lens wear. So you're going to explain the patient to the patient your diagnosis and what needs to happen. So this would be typically they'll use actors who have not quite a script but a brief for what to follow, and they will react according to the questions that you ask. Or it could be that there's a record card which says you've done the examination, these are your findings, explain them to the patient. And one of the things that you've got to get used to for the OSCEs is that it'll feel odd to have not done the examination but then explain the results to the patient, and just practice in your head how you get around that. So potentially you would say, right, okay, I've examined your eyes, and we have a serious condition of the cornea, which I think is due to your contact lens wear. I think it's potentially sight threatening, and I'm going to phone up the hospital to arrange for you to be seen today, ideally by a corneal specialist to try and treat this before it causes you problems. Now potentially the patient, and this is where OSCEs get very difficult, because the patient could have been told that they need to say, oh, I'm going on a business meeting and I haven't got time, and I've got a job interview or some other thing to try and put you off your course of action. But if they're saying to you the patient has keratitis, you might find that they say to the patient, try and say that oh, I can't go today, can I go tomorrow, or can I go next week, or something of that kind of feel. But what they're looking for you is to explain to the patient, no, you must go today. If you do not go today, there is a potential for sight loss which will not be recoverable. So that's potentially the kind of thing they could look for. So you explain to the patient diagnosis of keratitis. I don't need to tell you how to diagnose that. What needs to happen next? Right, you need to go to the hospital. You need to cease contact lens wear. You need to take your contact lens case with you to the hospital and your bottle of solution. That would be a good thing to say to them, because then swabs can be taken to see if there's what particular bacteria is on the lens or the case, or potentially in the solution bottle. So all of those things are important to say, and that's the kind of thing that you want to get through to them. I appreciate that's not an easy thing to do, but it is. You must cease lens wear immediately. You must take your case with you. You must take your solution, and follow the advice of the hospital. And do not return to contact lens wear without being examined again by us. The other things you could say is that potentially the patient should say to you, well, will I be able to wear contact lenses in the future? So it's too early to tell, but we may well have to look at a different contact lens modality, possibly gas permeable lenses, which reduce your risk of keratitis, potentially swapping from a monthly lens to a daily lens, or from an extended wear lens to a monthly lens, or to a daily lens, or reducing the hours of wear time, and all these sorts of things. It all opens up depending on what the patient's been asked to say. So that's what I would cover it with to begin with. The next one I came up with was a reduced vision, history and symptoms, and you give the diagnosis. So on some of them, the patients have a history. You just have to make your diagnosis from history and symptoms. So in this example, the patient may sit there, right, okay, right, when was your last eye test? What's made you decide to get your eyes tested today? Patient says, oh, I've got hazy vision. And say, right, okay, how long have you noticed the hazy vision for? I've noticed it for this time. Did it happen suddenly, or was it gradual? I mean, that's a critical question for most of these sort of vision drops. And if they say gradually, so okay, over what period of time did it become worse? You still got to ask all your questions about flashing lights and floaters and all that kind of stuff. How's your general health? What medications are you taking? And then that's the one where the patient would potentially turn around and say, I'm taking steroids. Okay, so how long have you been taking the steroids for? Boom, you've got your steroid-induced cataract as a likely cause for the visual symptoms. You ideally need to give a differential. So that could be potentially a corneal problem, hazy vision, glare, but cataracts obviously the most likely one. But on the ones where you have more, where you can't really carry out an examination and you don't have the time to talk about, well, I need to do this examination, they'll say, no, right, give your diagnosis. Say cataract, and if you can come up with something else as a possible, that I think is a worthwhile thing to add in, because it shows that you can understand that you can't come up with a definite diagnosis in just history and symptoms. It is possible, but it's difficult. So therefore, if you said cataract or a corneal problem, because hazy vision could be corneal dystrophy, and glare as well, could be corneal edema, corneal dystrophy, those types of things. The next one, the Volk station, and as far as I'm aware, pretty much every one of my pre-regs has had to do Volk at the assessment, the critical thing with the Volk exam is to read the instructions outside, certainly from memory, one of my pre-regs had a scenario where it said write down the letter or the symbol in the superior temporal area of the retina, and so what he did was panic and write down everything, and he failed the Volk station for that. And why he failed it is because the question said write down what is in the superior temporal area, and he wrote down all of those, and he'd taken that Volk exam to be a question of can you do a Volk correctly, and what I think what they were actually looking for was, do you know that when you're looking at an image through the binocular indirect systems of the Volk system, that it's upside down and back to front. But if you fill in all of the boxes on such a thing, they wouldn't actually know whether you know it's back to front and upside down, because you just filled in all of it. So that's the thing to be aware of. But the dummy eyes are actually very easy to work with. So I don't expect that to be too problematic for most students. But do practice Volk as much as you can if you're not using it already, because that's pretty straightforward to come up. The next one I came up with was on history and symptoms. You need to give a diagnosis. So a lot of the diagnosis from the history and symptoms will be fairly obvious as long as you've asked the standard history and symptoms questions. So you would always ask patients, do they have flashing lights or the floaters? On something like a flashing lights floaters one, I would probably expect the patient would say, when you say what's the reason for your visit today, I've noticed things flashing around in my vision and a constant shadow in the upper area of my right eye, for example. And again, this is one of those ones where they will typically have, the patient says they're a businessman and they don't have time to go to the hospital, and can they leave it for a few days and this and that. And again, that's to try and make you back down from saying you must attend the hospital today. So you'll say to the patient, right, yeah, when was the last time your eyes were tested? Okay, right, so you're getting flashing lights and floaters. Which eye is in it? How long has it been? Have you had any recent eye surgery? Have you had any bangs on your head? Have you had any head trauma? Are you highly short-sighted? A good question on a sudden onset or suspected retinal detachment, if the patient's not sitting in front of you, not wearing glasses, you could ask them, have they had laser eye surgery in the past? That would be something that would, be a potential thing where they were a very high myope and through laser eye surgery have had the prescription corrected, so therefore they're not wearing spectacles, but the eye is effectively highly myopic. So obviously you're not going to get a chance to examine inside the eye, but if you've asked flashing lights floaters, is there cobwebs in your vision, are there any curtains or shadows across your vision, those would be the things that would give you that idea. So yeah, and then you've got to sort of force the patient into going directly to the hospital for something like that. Even if they say I'm not going, you say, well, if you do not go, you will lose your sight and it will be permanent loss of sight. Okay, let's look at another one. Right, assess a record card, discuss the findings and actions. So on this one, everything's okay, but you've got a visual field defect, and it's a bitemporal hemianopia. So on these kinds of scenarios, the visual field defects that they would really want you to be, I would suspect, give you fairly obvious ones. I couldn't see them giving you just some random dots messed around, because that isn't something that you can really be expected to get a correct answer, and also your answer could be, I'll just recall them for another visual field test to see if it's just the patient not quite getting the test properly, but they may well give you a bitemporal hemianopia or a quadrantinopia or an altitudinal defect. So you must know your visual field defects and also the action. So anything that is neurological, that's an emergency referral. If you've got, if your knowledge is really up to date, then you should be saying a bitemporal hemianopia. Okay, this could be something pressing onto the pituitary. This could be the pituitary gland pressing onto the optic chiasm, and be able to sort of say this is why I think it could be. But obviously an MRI scan is required as an emergency. Assess a record card, describe the findings, diagnosis, patient can drive and your management. Patient 17, an amblyope. and I see 624, 626, and let's say, okay, so right, so this would be a patient asking. Oh no, this would be an examiner asking you about a patient and what they can do. So obviously you'd need to know the driving standard, and potentially you need to say that the driving standard is the patient must be able to see a number plate in good daylight at 20.5 meters, and have a full visual field, and also acuity better than or at least 612, no, better than 612 acuity. In this case, the patient does have better than 612 acuity, so therefore they can drive, but because they've reduced vision in one eye, they can't drive an HGV. And also, if something happens to their good eye in the future, they may not be able to drive. RX, should an RX be issued? 624. It depends on the details. So, say for example, it says 624. No improvement with pinhole, or the prescription is pretty low, then you could say that doesn't need to be issued. But if the patients find it better, then it would. Oh, pretty okay. Okay. Look at a record card and a picture. Discuss diagnostics with the patient. Reassure patient was a picture of a subconjunctival hemorrhage. Patient asking if we'll go blind, etc. So these sorts of patients are they're designed to make sure that you can deal with patients on an empathetic basis and not get overthrown, but get angry, I suppose. So can you act in an empathetic way? Can you understand a patient's concerns? Can you reassure them? Things like that. So there's a picture of a subconjunctival hemorrhage. So you'd be saying to the patient, okay, is this the first time that you've had this? How many times have you had this before? Do you have any problems with your blood pressure? Okay, so the most likely reason for this is that perhaps your eyes were a little bit dry, or you've had something go into your eye. And then the patient will start saying, oh, am I going to go blind? Am I going to go blind? No, this is not a sight-threatening condition. This is a fairly minor condition to occur. Don't worry too much, that type of thing. History and symptoms of a kid 15, they've got headaches, and what further tests would I like to carry out? So a child with headaches, so you're doing the history and symptoms with the mother, and no obvious reason could be found from the history and symptoms. They're constant for a week, not studying, etc. Had sight test last year, never needed spectacles, not having problems with vision, no family history of amblyopia, mother not noticed any turns, diplopia. Extra tests you do. So this is looking for neurological signs from an eye test. So visual fields, pupils, monocular colour vision, and you would also probably say the city test as opposed to the Ishihara test, because you're looking for an acquired colour vision defect. BV tests, motility, cover test, fixation disparity, all are potentially worthwhile doing. Cycloplegics, refraction, fundus examination, and obviously that isn't actually listed on there, but fundus examination, looking particularly at the optic nerve, looking for signs of papilledema, and things like that. For fundus examination, you'd probably say you want to do binocular indirect as opposed to direct ophthalmoscopy, so you get a stereoscopic view of the optic nerve head. Okay. Assess a record card and discuss findings with the patient, prognosis and possible treatments. Patient's keratoconic, so explain what keratoconus is. So, right, from the findings today, we've noted that you have a condition that's called keratoconus. This is a condition where the cornea, the front surface of the eye, becomes progressively more distorted or more conical in shape. This leads to increasing astigmatism and the requirement for stronger and stronger spectacles, and in some cases the spectacles are unable to give you a good level of visual acuity or good level of vision because of the level of distortion that's occurred. So in those cases we can look towards a specialist type of contact lens called a rigid gas permeable contact lens, and in fact for higher levels of keratoconus specific designs of lens are available to treat keratoconic corneas. A patient will then ask you if they will need surgery, and you would then say, sometimes corneal grafts are required or corneal transplants are required, but that's a last stage treatment. The important thing you'd also say to the patient is do not rub your eyes, because rubbing your eyes can make keratoconus worse, basically. You explain to the patient you'll refer them to a hospital as monitored there, asked about if they will get it in the other eye. Hard to say for sure, but is a possibility. Patient had come in with a gradual reduction in VA with new RX was 6.6 in the keratoconic eye, so told him VA is still good. Not sure if might have got VA mixed, but overall station didn't go too great. So this is actually feedback from one of my pre-regs on one of the stations that he had. So it gives you an idea of what can go wrong. So really practice. If you see a keratoconic patient, if you see a patient with cataract, if you see a patient with macular problems, if you see a patient with glaucoma or any other kind of eye disease, you must get good at explaining these things to patients anyway, but you must really practice at the moment pre-OSCEs, simply because if something comes up and you have not practiced those kinds of scenarios, it is extremely difficult to get it all out of your mouth. So there we go. Right, let's have a look at the next one. History and symptoms for a patient. They have diplopia and have plus 1.5 specs for both eyes for 1 month. The distance vision is fine, but the horizontal diplopia at near after an hour or so of close work. They said decompensating exophoria made worse by plus possible solutions. Take glasses off for near, reduce the prescription, eye exercises, prisms. All those kinds of things are things that you've got to be able to get into your head for a diplopia. But the fact that they were getting it after an hour of close work is what they would be looking for in terms of differential between a sudden onset diplopia, like a sixth nerve palsy or something like that, because that would be a constant in the distance as well as the reading, whereas a decompensated exophoria would be worse after time. Let's look at another scenario. So this was another one, an ophthalmoscopy station. You've just got to look and describe everything. There's possible notching, which I think was wrong. Didn't mention isn't rule. Said CD 0.5 deep, and everything else is normal. So really, that doesn't look very good in terms of description for ophthalmoscopy. So if you're going to look at the disc, does it meet the isn't rule? CD ratio, depth of cup. You can't really measure it with an ophthalmoscope. You're going to say shallow, medium depth, quite deep, lamina corposa visible or not visible, AV ratio 2 to 3, if it is 2 to 3 obviously, macular, brisk, clear reflex or not, as the case may be, and so on and so forth for that. Another one, and this is the thing to be aware of, is that it's not just going to be pathology or communication that can be covered in the OSCEs. They may well ask you about a dispensing, and I'm fairly sure, I recall one of my pre-regs had to fosimeter some bifocal spectacles, write down the prescription and things like that. So don't just think about pathology in terms of preparation for OSCEs. So in this scenario, the patient's a high myope, -10, -11, never worn spectacles, just contact lenses. They're 20 years old, fashion conscious, discussed the frames. There were 4 frames available to see with the patient: a rimless one, a supra one, a plastic frame and a metal frame. The patient wanted rimless, but I advised against. They went with plastic specs, as advised this hides the thickness, and advised high index. Didn't take any measurements at the station, didn't ask. Also forgot to put the patient to get the patient to put the specs on. So in this scenario, the pre-reg is given a patient, told they're -10 or 11, given 4 frames, and give your suggestions to the patient. So, you know, what would you do in practice with somebody who's -10 or a -11? Would you give them would you dispense a rimless pair of spectacles? Would you dispense a supra pair? Would you dispense a metal frame? Those are all not great choices for somebody who's a very high myope, even with high index lenses 174, and if the patient said they want this as thin as possible and they wanted glass lenses, then obviously rimless and supras are out of the question. In terms of the choice between a plastic and a metal frame, a plastic frame is the best choice for the patient. Although it is interesting that in all of that discussion, the pre-reg in that scenario forgot to tell the patient to put the spectacles on. So it's difficult, because you're just going to be judged on what the examiner sees you do and what you write down. If it's a written question, if there's a written sheet that you're going to do for that patient, or if they're just doing an observation on you. So, but plastic frames in general are the best choice. You want to have, you want to know the basics, like, so for example, the lenses are well centered horizontally and vertically, in order to mean so the pupil centers are aligned, and there's not, the worst sort of frames would be, like, say for example, a high minus, a plastic aviator, because then you would end up with a massive blank sized lens, which would give you very poor cosmetic appearance. Okay. And then there was another one. The pre-reg had to explain to the patient that the patient has wet AMD. So they'll potentially show you a picture, say, right, okay, explain the diagnosis to the patient. A case record: patient attended with recent onset of distortion in their vision. AMSLA shows distortion. Photograph shows evident wet AMD. So you would explain to the patient, right, okay, the results of the examination show that you have a condition called wet macular degeneration. This condition requires immediate treatment. So I'm going to be writing to, I'm going to be faxing a letter to the hospital using the wet AMD pathway, which will mean that you'll be seen within a week. If you get a sudden drop in your vision from what it is now, then come back in and see us, and I can contact the hospital and try and get you seen even sooner. When you're sent to the hospital, they will do some scans of the back of your eye using a machine called an OCT scan, an optical coherence tomographer. This will allow them to be definite about the existence of the wet AMD, and then you will be given treatment. The treatment will be an injection into your eye, and they will numb your eye beforehand, so it's as comfortable as possible. And you will be attending the hospital for monthly checks on an ongoing basis until the condition settles down. The injections that you're given, they will not bring the vision that you've lost back, but hopefully they will slow the progression and ideally, hopefully, stop the condition from getting worse. Although, that's all you can really say. You would also say to the patient, if you smoke, you must stop smoking. Eat your vegetables. When you're out in the sun, wear sunglasses or a UV protection in your spectacle lens. Those are all things that you can sort of explain to the patient as ways to reduce their risk factors for AMD deteriorating. Right, okay. And another one that comes up fairly regular actually is safety glasses, because safety glasses aren't things that you often deal with, but are certainly a core part of what an optometrist does. So you advise a patient on safety spectacles and usage and things like that. So on this scenario, the patient's struggling with close-up work tasks for the last 6 months. They're 45, so that's presbyopia. The first test, no previous specs, uses safety specs from the DIY store, so they're planos. Recommendations for a carpenter, plays football and drives. Patient distance is 6'9", and 6 unaided, so they don't need to wear glasses for playing football, they don't need them for driving, but if found, would show the patient if found beneficial will give with MAR. So this is unaided acuity of 6'9", aided acuity of 6'6". So must the patient wear spectacles for driving? No is the answer, because they're not at an acuity level of 612 or below, although you could say to the patient that you must check yourself by going out and looking at a number plate at 20.5 meters to make sure you're comfortably within the driving standard. If you feel that is difficult to achieve, then you may well benefit from the use of spectacles for driving. I think they've put it as 6'9" in the past, simply to make it not a definite. So say for example, if the patient has 6'6" unaided, then you're not going to talk to them about glasses for distance, because that doesn't make no sense. But equally well, if the patient's 6'15" unaided, then they're going to need to wear glasses for driving for sure. Whereas 6'9", 6'12", it's borderline. So that would be, I think, what they're looking at there. Are you able to advise the patient that it's worth considering, but you wouldn't say to them they must wear them? And then safety goggles as a carpenter, medium impact resistance advised, near vision only as first time RX, so bifocal, varifocal next time. Said not to use old safety specs as might not be safe. These are all very standard things to say. With a carpenter, would you suggest varifocals versus a bifocal? With safety glasses, you've got to work out with the patients, what the tasks the patient's doing. If they need to wear safety spectacles on their work site all the time, then a single vision near one I wouldn't be suggesting, because obviously how's the patient going to be walking around in a single vision pair? They will struggle to do that. So therefore you need to be looking at a bifocal versus a varifocal. If somebody's a carpenter, they're dealing with straight lines over a decent level of distance. Therefore you might say to the patient, actually a bifocal would be better than a varifocal, because with varifocals you get some distortion in the peripheral zones, whereas with the bifocal you do not. So that's the sort of things that you need to be thinking about. Right, that pretty much covers the things that I could come up with for the scenarios that I could run through. So I've written through 14 scenarios. I appreciate that it's a bit wishy-washy, but the nature of the OSCEs is actually very difficult to sort of really work out into something that you can discuss easily. But these are scenarios that have come up for sure. So it's worth watch. I've got some other scenarios that I can run through on OSCEs, which I'll try to get up in the next week or so, because I'm conscious of so this is the 25th of Jan 2017, so the next OSCEs are in approximately 6 weeks time. So there will be a number of people looking to do OSCEs, and I'll try to get some more scenarios up, just to give a flavour of the sorts of things that could come up. In truth, the breadth of things that can come up is huge, and that's the thing that makes the OSCEs difficult to deal with, is that frankly anything could come up, and so you've got to be practicing everything really. Um, yeah, the communication ones I would have said are the things that you can practice the most, and also practice with patients things that require that communication skill, and really get good at it, because that's what you're being exactly examined on really. That's great. Thanks very much.